Hello, I'm Dr. Robert Merchant, the Medical Director of the Reno Vein Clinic. Today I'd like to invite you into our procedure room where you'll have the opportunity to observe while I perform some of the basic steps of radiofrequency ablation. First thing we're going to do is we're going to do the radiofrequency ablation of the left leg. Okay. Going to pick your leg up here, Peggy, and then kind of roll it out a little bit. Allow it to roll out. Oh, perfect. We'll begin our radiofrequency ablation just below the knee. I take my dissector, which has got two flat blades curved blades on each edge. And this gives me an idea, casts a shadow underneath the ultrasound probe, right overlying the vein, and then I imprint it on the skin for a moment. And I can see a little bit of an imprint on the skin.
Is that what I thought it was? Mm-hmm.
Peggy, going to be a little sting right here. That's the local going in the surface. And one of the techniques that I use in surgery here for the vein work is using what we call the number 11 Bard Parker blade, which is kind of coming in at a double angle here, and only on one side is there a cutting edge. We can show this later a little bit better. And what I do is I start out with a small, tiny little incision. It's about 1 millimeter. And the basement membrane of the skin is where the scarring occurs. So if we can keep that at 1 millimeter or below 2 millimeters, then we can reduce the scarring to just a small little spot. This is a 2 millimeter diameter blade, and it pops through. And what I've done is I've stretched the basement membrane in the skin, stretching it rather than cutting it, so it's more likely to return to its smaller size, 1 millimeter. And then there we go. We'll go in and enter, find the tip. Should be in. Yep, we're in. We got a little back flash. You can see the point actually drop away from the back wall. I'll take that. And I'm really slowly, carefully touching it as I go in. If there's any obstruction, I know I'm not in the vein lumen. That went in smoothly. This was about as, this access here went about as smoothly as we normally see. Okay, and I put it in. We have more local anesthetic. Got a longer needle, 22. I make sure that the guide wire is far out of the introducer when we start to do any maneuvering, and then we can see the shadow of the guide wire going into the vein. I'll check it. I make sure that the guide wire is outside the introducer as I advance it, giving a little twisting motion. There's going to be a little pressure here, Peggy. A little pressure there. You should have gone in smoothly. The wire is still there. I advance it slowly. There's a little bit of a resistance here because I'm kind of dilating the skin as well. And I take out both the introducer catheter and give me an idea here, roughly gauging the distance. It's about two segments above the spiral segment in the radiofrequency catheter. Inserting it. And then I'll go ahead and just slowly advance it up the vein. If I reach any obstruction, I feel it oftentimes before the patient does. And that's the whole purpose of advancing slowly to see if I've got any issues. If I run into an issue, I slow down and put in a guide wire. But this one went smoothly right up to it. Let me see. Let's give me this. What do I do now? I've got the needle, or the tip is right there. Yeah, hang on. We're right at I go longitudinally here. Okay, we're right at the junction. And what I'll do is I will withdraw it. Actually, just a little beyond the junction. But here we are it's about 1.5 centimeters. We want to be 2 centimeters from the junction. And this will change as we reposition the patient. As we tip the leg up. I'll go ahead and use that. Now, I'll put in, I do this introducing my tumescent fluid about every 10 centimeters apart. I can actually feel the catheter below me, below the skin. Could be a little sting right here. Try to do a little counter stimulation when I introduce it. This is just a small amount of local. A little sting here, Peggy. And another one right about here. Another little one right about here, Peggy. You're doing great. Peggy, are you doing okay up there?
Yeah.
What you're feeling a little liquid is the local anesthetic trickling down. And one up here in the groin. Okay. We do this auto refill syringe technique. I found that it's a lot easier to guide it. I know where my needle point is. Unfortunately, you can't aspirate on this, but I can see the flow going. Little pinprick here, Peggy. There you go. And I have to turn this the correct way. I can see. There's the needle point right above the vein. The nice thing is that we can see the vein because it's got the radiofrequency catheter within it. And what I'm doing is I'm attempting to obtain a kind of an onion skinning effect. Thanks, Rachel. Okay. And as long as I stay above the fascia, very little discomfort with this. If I get below the fascia, then I'm into the muscle area, and just poking it will create a disturbance and a little discomfort in the muscle. And so if you put in any local, you can't numb up the muscle very well at all. So I just avoid it as much as I can. There we go, right above the vein. And as long as I'm infiltrating, I see the expansion around the vein. And that gives me pretty good confidence. Now, this is a good example right here. A little disturbance in the vein itself, turbulence in the vein, means I'm actually in the vein. And so I entered it there in one small spot. Patients don't normally feel it because they've already anesthetized the vein. Here we use intravenous sedation and a minimal dosing just to kind of take patients down into a light relief of anxiety and relief of any type of pain or discomfort. It kind of blunts it a little bit. And at the same time, the agents were said, midazolam, generic name, is really it's a diazepam, and it has some anti-seizure activity, which is the main issue with lidocaine, is a potentiation of seizures if you get too much in a rapid concentration. It doesn't take much at all, really, maybe 50 milligrams intravenous. We've never had that issue here. One of the other side effects of the lidocaine is that it creates arrhythmias, and so we monitor our patients very, very closely when we're doing this. Arrhythmia is maybe a bradycardia, and that happens, I think statistically, about 0.15%. So it's about 1.5 patients per 1,000. In our experience, that incidence is actually lower. I think it's because we monitor our introduction of the local anesthetic very closely. Okay.
Good.
All right, we're ready to reposition the patient. I checked the entire line here. By elevating the leg to 30 degrees, on this Ritter table, it goes to 30 degrees almost perfectly. We've checked the angle on it. And when we do that, I think it empties the vein of fluid and brings the vein wall right down around the catheter tip. Now, when we started, we were at 2 centimeters from the saphenofemoral junction. And we're about 1.5 centimeters. So it's advanced just because of the positioning. So I pulled back about width of the full screen, which is about 2 centimeters from the junction. Junction's right there with the black cloud about halfway up the edge there. There's our vein, great saphenous vein in the middle. Okay, we're ready to go. It's a little coagulum developing, little alteration in the protein. We do a double treatment at this area. Okay, we wait till it reaches 75 or so just to cool it down between. If we try to do it too quickly following this, I think that the heat dissipates into the tissue and the patient, it gets outside the anesthetized region, and the patients can sometimes feel it. Since we've started to allow it to cool down, we haven't had that issue. So it only takes about 10 seconds between. So that's 2 now, and what we're going to do now is withdraw it. Okay, do it again. And it heats up to 120 degrees centigrade, but it takes 20 seconds, but the first 5 seconds is the actual ramp up to that temperature, so it's only at that temperature for about 15 seconds. And go ahead. Pretty long 20 seconds though. We get up here to the little spiral end that's warning us. Go ahead. That we're getting close to the end. It gauges with or it's matched with the 7 centimeter introducer length. And this is basically tells us it marks it at 11 centimeters. Some people you need a larger introducer. So this is geared for that. Now we'll remove that. You have a sponge, please. Here we go. I advance it. And there we go.
Go ahead.
Okay, just a moment. Okay, go ahead now. There are like 4 little interrupted dots on the catheter that warn about 2 centimeters to the heating element, and that I position them just below the skin, so we're 2 centimeters below the skin. And you can see here that the catheter is a little bit outside or the introducer is a little short. And then what I'll do, there are the little dots. I just felt it now, it's coming out of the vein, so it's about that far in near the skin. And just in case, I wait until it's below 75 degrees centigrade, and I pull everything out at once. I pull it back into the catheter sheath before I remove it. And that helps guard against the any thermal injury to the vein, to the skin. Okay, Nan, we can bring the leg down. We're done with the elevation, so the rest of the procedure will be done with the patient pretty much in a supine position with the legs just mildly elevated.